Thank you for those kind words, Amma. I'm married to a obstetrician and a gynecologist, so there will be a lot of hesitation to speak loudly in front of them, but I will try to do my best to convey what we understand today when we say renal disease in pregnancy. As the people who introduced the whole program conveyed, motherhood completes womanhood, and every married woman or sometimes even unmarried women want to become mothers. But there is a lot of changes that happen inside the body of the mother, sometimes leading to some pathology, and kidney is one of those organs which gets a lot of changes both physiologically and when there is a damage. The only other organ probably or the system which goes through so much change is the immune system. When we were MBBS students, we were told if you have rheumatoid arthritis in a lady and it is refractory, get her pregnant. They did not mean by the doctors but by the husband, but you should make them go through pregnancy so that their rheumatoid arthritis comes down. In other words, the cellular immunity is suppressed, whereas the humoral immunity is stimulated. And these changes, if you just simply summarize, most important to us for discussion today's topic would be the increase in the cardiac output, plasma volume, but some mismatch between the blood flow and the renal plasma volume, leading to a GFR increase of around only 50%. But what is important for everybody taking care of these patients to understand is, please note the kidneys are at what we call as the maximum capacity working. So the concept which is probably novel to many of us is something known as renal functional reserve. Just like your heart rate increases when you run, you can have your GFR increase when there is a stimuli. Sometimes these stimuli are physiological, like in pregnancy, but once you have recruited the reserve GFR, you hardly have any GFR left to recruit if there is a need. So in other words, somebody's renal functional reserve is totally used up during pregnancy. So any insult can lead to a severe drop in GFR or acute kidney injury. And the most important thing is, this can become chronic. So with this concept in the background and the importance this topic has, one of the ADKEs is a body which does guidelines for many things, especially acute kidney issues. So in 2024 January, there was a 32nd ADKE done in Hyderabad, and around 5 papers came out of it, and they are just accepted to be published in Nature reviews now. They should come out this year. Let us start with a patient. This is a 31-year-old lady, married for 6 years. The obstetrician had seen because of they failed to get pregnant for 6 years, then found that the patient had 1.8 creatinine. Was sent to the nephrology team, 2,800 milligrams per day. So diagnosed as chronic glomerulonephritis. A biopsy was done which showed chronic damage. So in other words, this is a CKD established. So the questions for us will be, can we plan pregnancy, which they are very keen for? What are the problems we expect? What are the maternal outcomes, fetal outcomes, and how do you follow up these patients? So today, if you look at CKD, we classify it according to the GFR and also protein loss. And sometimes the protein loss is more important than the level of GFR, dictating how fast they reach dialysis stage. So this particular patient was treated with steroids. Creatinine came down, protein loss came down to 310. We allowed her to get pregnant, and then there was a pediatrician in picture towards the end of Haridhi, and she had a successful pregnancy. So there is a lot of data that you will get in the literature talking about pre-pregnancy counseling for people with CKD, and this becomes extremely important. So this is data from UK where Dr. Krishnan Naini talked of. They did a very good job compiling together what are the type of problems that you would expect. So most often it will be CGN, and as I already mentioned, these patients will worsen their protein loss as soon as they get pregnant. They may have asymptomatic disease, but the minute they get pregnant, proteinuria increases by 1000, 2000, 3000. And that is what allows them to progress very fast. The other diseases would be obviously something that can trigger off in pregnancy, like lupus, FSGS, which can get worse, reflux nephropathies, diabetic nephropathy, hypertensive nephropathy, stone disease, and a small subset of patients who have had a transplant in the past. So what are the things that they found in their cohort of patients? Around 277 controls versus 35 patients. Preeclampsia was quite common. Small for gestational age was quite common. Preterm delivery was very common. And of course IUGR, whereas maternal death and fetal death were very rare in the CKD population who got into pregnancy.